Invite Dr. Vinod for his talk on CMV retinitis.
Uh, Good morning, everyone. Rather, good afternoon. So, I'll be talking about CMV retinitis. Now, there is always subtle differences between AR and CMV retinitis, and once you are new in the field, you might confuse between the two. I'll be showing you a few cases. The idea is just to make you recognize that how these two differ from each other, as compared to some other viruses. CMV or cytomegalovirus is a ubiquitous virus. It is seen in approximately 40% of the normal population, and usually most of us would have this virus in the eye in a latent form. Now, once a person is immunocompromised, this CMV virus gets activated. It acts as an opportunistic infection. While typically we had seen CMV retinitis, lots of them with AIDS and HIV, but with antiretroviral therapy now prevalent, this incidence of CMV retinitis in these cases on the decline. However, the other immunocompromised states, for example, chemotherapy, organ transplant patients, and even the patients who have been on steroids, it's not uncommon to see CMV retinitis in these cases. In fact, it is again, remember, any immunocompromised state, you must think of CMV retinitis and not only AIDS. So typically, again, CMV retinitis usually would start in the periphery, especially the one which is in the indolent form. So these patients can be asymptomatic, or they may present with floaters because of vitritis. Sometimes because of inflammation, there might be mechanical stimulation or chemical stimulation of photoreceptors, and these patients can present with flashes as well. And of course, once there is involvement of the posterior pole or there is significant haze in the vitreous, the patients can present with blurred or decreased vision as well. Very rarely what will happen is a patient who does not come across any of these symptoms can develop retinal detachment, and then patient can develop present with sudden onset loss of vision as well. And if there is involvement of the posterior pole in terms of macula or optic nerve, the patient can present with markedly decreased vision. Now, have a look at this particular patient. He presented to us with decrease of vision in the left eye for past 1 week. But when we examined him, you can see there's a large area of retinitis, not only in this eye, but also in this eye. So you can see there is active granular form of retinitis which is there. It is healed, but the macula is normal. So patient never got to know whether he had something. But once he developed retinal detachment in the left eye, he presented to us, and at that time we noticed that patient had CMV retinitis, and this patient subsequently underwent surgery in the left eye along with oral valganciclovir therapy. So remember, as compared to ARN, here we give valganciclovir as compared to valacyclovir. So dose is 900 milligram BD typically for 2 to 4 weeks till retinitis heals, and once the retinitis heals, you can shift to maintenance dose 900 milligram OD. Now remember, as compared to ARN, typically CMV retinitis will happen in immunocompromised status. So you need to continue the antiviral therapy till the patient is immunocompetent once again, whereby the patient's immune system is able to fight the CMV virus. Otherwise, it will keep on recurring the disease. And in this patient, in fact, RD was a boon for the patient. Otherwise, he could have presented later on when the macula and optic nerve atrophy. So this is another patient. If you see, there is large involvement of the periphery, almost reaching up to the posterior pole in the right eye. And this patient again treated with valganciclovir therapy, and you can see there's nice healing. This is the typical pattern of healing. It leaves behind some amount of pigmentation, and there would be some areas of granularity which will resolve slowly. This is the other eye of the same patient. You can see there is granular form which is limited to the periphery, and once you treat these patients, they can heal very nicely, leaving the posterior pole intact. But as I said, remember, these patients need long-term therapy. This is the second form of CMV retinitis, where you can see there is more aggressive disease, more posterior disease, and much more hemorrhages. And once it happens at the posterior pole, you can see that it eats up the macula, it destroys the optic nerve, and these patients can present with very poor vision. So this is how it heals. You can see, though the disease has healed nicely after therapy, but the macula and optic disc both are destroyed, and the visual prognosis remains poor in these patients. So again, and this is the other eye of the patient. You can see there's extensive peripheral healing along with activity at the edges. So this is a typical pattern whereby the peripheral healing keeps on happening and the new activity starts, and slowly it progresses to the posterior pole, and if not treated, it can eventually lead to destruction of the macula and the optic nerve. So this patient in fact had RD, and this patient underwent surgery, thereby leading to attachment of the retina, and we could preserve some ambulatory vision in the left eye. So that these were most of the HIV patients, but remember, aggressive form of disease can present in other forms of immunosuppression. For example, this young male with acute lymphoblastic leukemia here, a typical appearance where there is a pizza pie appearance with retinitis, lots of hemorrhages, and these diseases are actually very difficult to control. This patient received not only oral Velgan but also intravitreal Velgan cyclovir. You can see there is healing at the center of the lesion, but the lesion has become larger. The main issue is that these patients are sick. Sometimes they are not able to continue Velgan therapy, and this retinitis keeps on progressing. So you can see there is central healing which is happening, but the lesion is becoming eventually bigger and bigger. And this is on OCT. You can see there is a full thickness macular retinal involvement, which leads to destruction and eventually thinning, leading to loss of vision. So this is the other eye of the same patient. You can see at the beginning there were few hemorrhages, some granular form here, but eventually again, because these patients are not very regular with therapy, you can see the disease becomes aggressive. There is severe disease which involves the macula, and you can see how the peripheral retina has healed, and now there is activity at along the whole edge of the previously healed retina. So this is the follow-up. This patient was eventually, that is what we could spare at the end of the therapy. By the time patient completed chemotherapy for his leukemia, this is what we were left with. So remember, this is how zones are described. Typically you have zone 3 and zone 2 disease, which is milder, but when it is happening in zone 1, it tends to be more progressive. So sometimes the patient can present with picture like this. You can see not only the retina is affected, all the vessels are affected, and this is what is known as frosted branch angiitis. And since many of time these patients are systemic malignancies, blood dyscrasias, you can confuse these with leukemic infiltrates. So whenever you have patient with hematological malignancies, please be very careful that you are not dealing with a case of CMV retinitis. Some other presentation, this patient, again one of the patients with SLE who was on steroid for long term, had a papillary CMV retinitis. In fact, this patient we planned for starting therapy, and the patient came very next day, and the patient had developed combined occlusion of central retinal artery and central retinal vein. So again, a patient with posterior aggressive disease. Patient was on treatment, and next time when he came, he had appearance of frosted branch angiitis. Since the patient was already on treatment, we did not do anything extra, and this patient eventually resolved. A very aggressive disease sometimes can happen like this, and which can destroy whole of the posterior pole. On the other hand, another patient, you can see mild peripheral disease which heals. So this is in fact the right eye of the patient when he presented, and this is the left eye, only small lesion. Again, a patient with hematological malignancies. You can see he heals, but again comes back. Again activity, heals, again slowly keeps on progressing. You can see how it is progressing slowly, and this patient in fact had a very severe kind of hematological malignancy, and by the time his chemotherapy was over, we are left with this, where CMV has destroyed virtually everything in the retina. So as I mentioned, diagnosis is mainly clinical. We typically use valganciclovir in the doses I mentioned, but remember, till immune recovery, you need to continue the maintenance phase. For HIV, we typically say CD4 counts of 200 to 400, but again, that is controversial. As mentioned, laser for the prevention of RD is controversial. Typically, most of the cases do respond to valganciclovir, but at times you may require cidofovir and foscarnet, which I don't have any experience with. Earlier, ganciclovir implant was available, but that has been discontinued because the CMV incidence has declined recently. And you need to correct the underlying immunosuppression for the long-term betterment of the patient. Thank you very much.
Thank you, Dr. Vinod. Such a wonderful collection of cases. So just to summarize a few things. So as to differentiate between ARN, since CMV comes through the endothelium, there is more incidence of hemorrhages there. Like he showed you, the classic pattern would be a pizza pie, hemorrhages also there. Although you have the granular form also, where you may not have so many hemorrhages, and the vascular form, the prostate branchitis, which he showed you. And if you would have noticed in the white patches that it showed you, most of them had some satellite white granular small lesions adjacent to it. That also is very typical of this CMV. And since these patients are immunocompromised, they don't throw up an immune response. Most of them you will not find significant vitritis. You will just find some AC cells and RL cells, but obvious gross vitritis you will not find in these cases. And regarding therapy, is nicely mentioned, valganciclovir is a very magical drug these days. But for a zone 1 disease, I would augment it. I would give an intravitreal, now a high dose ganciclovir. Earlier we were giving 2 milligram. Now we give 6 milligram, which can be given once a week rather than twice a week. So if it's a zone 1 disease, I would be a little more aggressive in treating and augment it with intravitreal therapy. Any other questions or comments? Yeah, Dr. Divya.
Sir, should we screen immunosuppressed people regularly for CMV retinitis? Because sometimes the patients who are on long-term hematological malignancies, they show up with, you have shown that small granular form of CMV retinitis isolated in the periphery.
I think that's a very interesting question because many of these patients are sick and actually are not able to report. But I don't think offhand there are any study which report such kind of screening in hematological malignancies.
Sir, I have visited few hospitals just for screening for ruling out papilledema, and incidentally I found these localized CMV retinitis patients in those cases, sir. So I would just as a query I asked.
Yeah, I think it's a very valid question, but the thing is, moment these patients have, as I showed, they keep on having ups and downs of the disease waxes and wanes. So moment they become immunocompetent again, their immune system becomes better, the CMV automatically tends to decline on its own. So that is a big plus in these patients.